on health inequalities and inclusion health. There are some people within Wales who are at greater or multiple risk of health inequalities, and inclusion health is the development of services which aim to overcome these inequalities to provide equitable and accessible healthcare. People experiencing homelessness, asylum seekers and refugees, gypsy traveller and Roma communities, individuals in contact with the justice system, and sex workers are more likely to experience stigmatisation, social exclusion, discrimination, and severe and/or multiple disadvantages. And they are more likely to have increased health needs, but are least likely to access primary care. Sex work is an occupation, and there are varying levels of occupational hazard that are associated with the different types of sex work. However, sex workers are a significantly marginalised and stigmatised group who face health and social inequalities. These inequalities are not limited to infectious diseases. Whilst sexually transmitted diseases are a significant occupational hazard for this group and prevalence is higher when compared to the general population, sex workers experience unfair and increased risk of chronic diseases, violence and trauma, post-traumatic stress disorder, substance use, and experience poorer maternal and postnatal health outcomes. Whilst this group have a specific lifestyle and occupational health needs, they are less likely to engage with primary care. So, what can and should the primary care system in Wales and those working with sex workers be doing to tackle these issues? Today's webinar will provide an overview of sex work in Wales and the barriers and issues faced by this group of people, and discuss their health needs and barriers faced by this group. Sorry, I've said that twice. It'll showcase services and initiatives which provide non-stigmatising support, ensuring access to timely, equitable healthcare across the Swansea Bay region. Our presenters today are Zoe Cousins, a sexual health programme lead in Public Health Wales, Joanne Tilley, the clinical nurse specialist in Swansea Bay, and Lynn Sanders of Swansea Women's Aid, discussing the SWAN project and sexual health services. A bit of housekeeping to start. The webinar will be recorded. The recording and slides from today will be made available on the primary care website after this session. After the presentation, there'll be a chance to ask questions, but please pop your question in the chat as you go, and we welcome contributions in English and Welsh. If you experience any difficulties with technology, please let us know through the chat and someone will contact you directly. If everyone can keep their mics and cameras turned off during the presentation, that would be lovely. And it's over to our first speaker, Zoe.
Thanks, Vic. Good afternoon. So I'm going to give you a perspective of sex work and sexual health from a public health point of view. Next slide, please. Okay, just to start with, an explanation of what sex work actually is, because for most people, street sex work is the key thing that people think of, but actually it's far more than that, and will be seen in different areas. So it's the exchange of any sexual service for money or something of value. It could be for a cup of coffee and a sandwich, if that is what the person needs. It covers erotic dancing, pornography, and more recently, web online sex services as well. Things like OnlyFans will fall into that as a category as well. And it's important to bear in mind sex workers have different reasons for doing sex work. Some are in circumstances where they don't actually have an alternative. It's their only way of getting an income, particularly around the last few years with increasing levels of poverty that we've seen in the UK. And that has led to an increase in individuals having to do sex work. Some actually choose to do sex work because they enjoy it. And then you have another group of individuals who are exploited, they're forced, they're coerced into the traditional elements of prostitution. And that's covered by sexual exploitation and human trafficking, and those are active crimes. Next slide, please. We use the term sex worker rather than prostitute, which is an old-fashioned term, because that is the term that sex workers have actually said on a global basis, that's their preference as a terminology. The main reason and the key reason behind using sex worker as a descriptive is that it actually makes us realise sex work is a job, it's not an identity. These people are everyday people. This is only the work that they do. Next slide, please. Looking at difference between sex work and prostitution, because that's another element that's slightly difficult to actually get your head around. Prostitution is actually the legal term for all sex work. And it, as I said, it includes everything from web-based to street sex work, pornography, both legal and illegal forms of sex work are covered. For prostitution, it generally is about monetary compensation and is covered as such. And there are many legal frameworks that distinguish between different individuals providing different services. And you'll often see sex workers, or you'll have pimps, brothel owners. So prostitution and the legal framework around it has a whole dictionary of its own. Additionally, you have the difficulty of understanding what constitutes a sexual act. And from a legal landscape, that can be very complicated to actually define. Next slide, please. There are many misconceptions about sex workers, and this is what we were trying to get people to understand. Often people think of sex workers as being women. As I said, street sex work is the image that comes to mind for most people. But the reality is that we have male, female, transgender and non-transgender sex workers across Wales, and they will come from many diverse backgrounds. The other aspect to bear in mind is for male sex workers, there's often a consideration that male sex workers are gay. They're not all gay. And often, even if you have a male sex worker with male clients, they would not normally identify as gay or bisexual. And from a personal perspective, when they're not working, they will have female partners for intimacy. Next slide, please. This is trying to get people to think in terms of actually what do you think of when you think sex worker. All of the individuals in this picture are actually sex workers. This is a photo that was published from New York to highlight the fact that people come from diverse backgrounds. It's not all one homogenous group. Next slide, please. In terms of the UK, and in particular Wales, it's difficult to get data, is the first and foremost. People do not wear T-shirts or even have tattoos saying they're a sex worker, generally speaking. However, we do know, and this is data from 10, 15, 11 years ago now, that every local authority in Wales does have a presence of people who are sex workers. It's estimated that at least 2,500 sex workers are based in Wales, with the vast majority working online. That will probably be much higher now. And then you have another group who work through the brothels and the massage parlours, and then the smaller group working on the street. Street sex workers, there's a piece of work that was done a number of years ago now into the pathways that has led them into street sex work, and looking at whether or not there were any links previously through social care, and determining whether or not there were points at which their path into sex work might have changed into a different occupation. And when a series of cases were looked at, 70% were actually known to social services departments in some form or other, and often had very, very lengthy history with social services and points at which things could have changed. In 2015, there was a specific study done by researchers in Swansea, Dr. Debbie Jones and Dr. Tracy Sager. And at the time, they found 5% of students were actively engaged in sex work and 22% were considering doing sex work. I suspect that that again has increased over the last 10 years with the changes in finances associated with students in particular. We do have Safety First Wales. I'll explain about that a little later. In the UK in general, there are nearly 73,000 sex workers, the vast majority, again, women. And it's important to realise that the female sex workers are often mums working to support their families. And of note, 70% of UK sex workers have previously worked in healthcare, education, or the voluntary sector. So this is not their only income source, but it's something that they've had to do as a top-up or as an alternative because it's their other forms of occupation have not been sufficient. Next slide, please. We have on the Test and Post service, which is the home STI sampling kits that we use, on the online service, we have a question about whether people have been paid or have ever paid for sex. And if we look at the data for 2023, then you can see that it's not a small number who answer yes to this question. And we know through the Test and Post that we have a fairly sizable adult industry in Wales because they are encouraged to test on a regular basis, and so they ask for their results as a result of that. Next slide, please. There are 4 basic legal frameworks around sex work, so it's important to bear this in mind, and they are built around whether the person is selling sexual services or buying sexual services. So in decriminalisation, neither are a crime. Obviously in criminalisation, both. You would be criminal for doing sex work or purchasing it. And if a seller is licensed, then it is legal. And then we have the entrapment model, which is also known as end demand. Nordic model is probably the more common framing for it. And for selling services, it's not a crime, but it does criminalise the individual buying services. And the idea is that it frees sex workers because they're often seen as victims. Next slide, please. For Wales, we have Safety First Wales. It's a coalition of sex workers, health professionals, church representatives, those who work with third sector to support sex workers. And they have had a formal launch of their briefing in the Senedd last November. And they formed as a group to first decriminalise sex work in Wales, but the aim is to prioritise the safety, the health and the well-being of sex workers. And as I say, it's a coalition primarily of sex workers driven by sex workers. Next slide, please. So to explain decriminalisation, it's actually the removal of all of the criminal penalties for sex work. It's a legal framework that is actually supported by Royal College of Nursing and a wide variety of other organisations, because the aim is to promote safety, reduce harm and enhance the well-being of those engaged in sex work. And obviously that is what you need to do more than it is the key aim for all sex work support. Next slide, please. It's different because it means that if you're consenting to buy or sell, you're not committing a crime. There will still be laws specifically around trafficking, rape, violence, sex work involving minors. Those laws exist anyway, it's a separate piece. But the appropriate model to apply for any kind of decriminalisation or legalisation of sex work is really difficult, because to have an evidence-based policy which addresses all the diverse experiences and needs of those involved in sex work is very complex. Next slide, please. It's important, certainly from a public health perspective, to understand the difference between a prostitute caution and a police or criminal caution. Prostitute caution actually lasts for the whole lifespan of the individual once it's on your record, or until you're 100, whichever happens first. And it actually causes a problem for individuals who are trying to leave sex work. It'll be on your DBS check, which we all love so much, the DBS check. And it actually means that there is less reporting of crime and violence against people who are doing sex work, because it then opens them up to have this prostitute caution. So it's the impact of having this is quite significant in more ways than just it being on your record. It's actually deterring reporting crime. Next slide, please. From a health need perspective, the current health provision for sex workers is very much around sexual health, and can be, not necessarily always, but can be to the exclusion of other physical and mental needs. It's a focus. And it's really important to bear in mind the physical and the mental health support that's required around this as well, and the wider services that might be needed, such as housing, whether or not services are referring correctly across different requirements for, as I said, mental health support, for example. And sex workers frequently hide their occupation out of judgment, fear, stigma, reduction to access to services and support. And that is a key issue. So it's very important that you consider whether the person in front of you could be a sex worker. Next slide, please. Speed up now. Barriers, poor access, stereotyping, unsafe discharge from A&E and secondary care for some, and poor follow-up are key issues that apply to this group and others who are in the inclusion health groups. Next slide, please. The Anderson model of access is really important to consider. This looks at core factors around enabling, the psychological, psychosocial factors, how people use services, and how you then tackle the barriers to facilitate better use of healthcare. Next slide, please. There are examples going back to the decriminalisation. The entrapment model has been used in Northern Ireland. It actually did not improve safety for sex workers. It did not improve the use of condoms, which meant that we had more STIs and there were more assaults. Next slide, please. So Johns Hopkins, they've done a review of studies which actually demonstrates what decriminalising does and how that changes things as well. Next slide, please. New Zealand, they have decriminalisation across the whole of the country, and actually it's promoted welfare, occupational health. It's an occupation, and safety was protecting against exploitation. Next slide, please. And the evidence was there wasn't an increase in prostitution, which is one of the concerns that there would be. Women are more able to actually report and not be fearful of having prostitute cautions, etc. And the rates of STIs have gone down, condom use goes up, and people are more able to leave prostitution and go into other forms of work. Next slide, please. Over to Joanne.
Thank you, Zoe. That was a really, really brilliant presentation, and provided a really good overview of what's happening in Wales and some of the things that we need to consider around how we support this group of people. So over to Joanne, clinical nurse specialist from Swansea Bay. Thank you.
Lovely. Thank you so much. Thank you for having me. It's great that we're finally, talking about this group in primary health. So yeah, thank you very much. So next slide, please. Lovely. So today I'm just going to talk from the health point of view, and obviously the Sexual Health Outreach Service here in Swansea Bay. When it comes to signposting, some of the things I'll be talking about will be national, all Wales, and some obviously specific to Swansea. So wherever your area is, have a little look at what's about. there's lots of things going on now, and like Zoe has said, you know, inclusion health is coming into the minds of primary care finally, so that's something to take forward. Next slide, please. Okay, so I think I might be covering a little bit of ground that Zoe's already covered, but it's just recognising that sex work always doesn't present in the way that we think. That image that we've got from media, stereotypical, like Zoe said, you know, it's just street workers. That's not always the case. Individuals come from diverse backgrounds, and you may see them in any healthcare setting, and to always be mindful that they're not going to walk in and disclose to you straight away that they're a sex worker. Both male and female sex work, but the figures for women are roughly 2/3 compared to men at 1/3. And you can see there on the slide lots of different ways of sex working, and especially now with the digital and online age, lots of people doing that. And as Zoe said, we're not always aware of the numbers because that's even more hidden in some aspects. Next slide, please. Again, some figures regarding sex work. Some a little bit old and a bit out of date now. And I think with the cost of living, COVID crisis as well, these are likely to be higher. As we know, women in particular are more likely to sex work to support their children and families. The Swan project I mentioned there, I know Lynn is next to speak after I finish, so I'll try not to pinch her material. But Swan are a fantastic local project in Swansea, from part of Swansea Women's Aid. And they support women who sex work through both daytime support and evening outreach. And we're lucky enough in sexual health, we've worked alongside them for many years now. The Reflect project, you can see at the bottom of the slide there, that's a government, part of the council, the local authority, and they support women and families who've had children removed into the care system. So we work alongside those as well in sexual health. Next slide, please. So not all sex workers fall into the complex and health inclusion community, so it's important to note that. But some of them do, and these are the barriers and complexities that come along with sex working and some of the inclusion help groups. And as Zoe says, we might need to be aware of these when we're referring onwards. They may need help that is outside healthcare. So things like criminal justice system, financial issues, all those kind of complex needs that can be outside of health. And it's hard when we work in healthcare, we tend to focus on health, but there's a much wider picture that we need to be aware of. Next slide, please. So this is in regards to sexual health. So why does sexual health matter to this group? For me personally, it's purely inclusive motive, reaching out to deliver healthcare to this group who are marginalised and suffer greater health inequalities. But as you can see here, we also have an obligation from a legislative and target-driven point of view. The bottom point on there is in regards to cost and making every contact count, even though cost, for me personally, doesn't come into it. It's a very person-centred approach, but we have got to be mindful that everything nowadays is cost-driven. So just wanted to highlight that as well. On to the next slide, please. So this is us in Swansea Bay Sexual Health. You can see there's lots of different fractions of our service, lots of different things we cover, and we are on there as the outreach service. Can I have the next slide, please? So this is us, the sexual health outreach team. There's 2 clinical nurse specialists, one of which is myself. We've got a nurse practitioner, some nursing associates, and we cover the whole of the Swansea Bay footprint. Some of the groups we support there, and like you'll see, a lot of them are inclusion health groups, but anybody who finds it difficult to access clinic in the normal way, we will try and support. Next slide, please. This is just our mission statement from the sexual health team, and I've put this up just to highlight really our aims about delivering compassionate care, working with partners, and the health board values here in Swansea Bay, caring for each other, working together and always improving. Next slide, please. So this is what we provide in sexual health to all of our patients. You can see there STI screening, bloodborne virus screening, vaccinations, contraception, counselling, the list goes on. We do a lot of onward referrals to our colleagues in primary, secondary care and also the third sector. We've also got from Public Health Wales the self-testing kits that we can leave with people if they're unable to see us at that time and place, and that allows them to do the testing themselves and post it off to Public Health Wales. Next slide, please. So our roles within sexual health, and especially the outreach service, is obviously the most important thing: non-judgmental, safe spaces for people to be comfortable and come and discuss their health needs with us. The outreach service, we see patients long term, so we're lucky that we have that repeat contact with them, so we get to build that trust and rapport and relationships with our patients. Patient-centred care, making every contact count. So, you know, especially with the more chaotic patients, we will try and do as much as we can in that one appointment for them. So, like I said, that might be referring to the third sector, speaking to their GP, if there's other health issues that we can't deal with within sexual health, referring wherever they need really, because obviously these individuals sometimes lead really chaotic lives. So it's, you know, as much as we can do, making every contact count. Trauma-informed care, this is always, you know, at the heart of our work in outreach. So trying to be aware of what these people have been through, the lives they are living, and they may have more complexities that we need to be aware of. We adapt our services, so outreach, the clue is in the name. We go out to patients in the community. We don't expect them to follow the, you know, the rigmarole of ringing clinic, being triaged, getting an appointment. We go out to them, take the care out into the community and do as much as we can for them. We try to make it easy access for them and change the way we work to fit around the patients. Signposting, so we do lots of signposting, and we wouldn't be able to do our job within sexual health. There's our lovely partners, which I'll mention a bit later, some of the third sector and primary and local care partners. We're always about health promotion and harm reduction, and again this might mean referring into other areas which have got more specialist knowledge about that. Multi-agency working and safeguarding obviously is everybody's responsibility. We do safeguarding as appropriate for that individual at the point of care. Next slide, please. So this, I just left this in from some training we did a little while ago, and that was for GPs as well. So it's just, if you're sitting there thinking, how can we adapt our service? How can we, you know, make things easier for people to access? Some of the solutions are really quite easy. Something like, I don't know, booking a double slot for a patient, bringing the patient back to see you, so they've got that continuity of care. Other aspects are obviously a bit more difficult. There might be training needed, trauma-informed training, But I think from a clinical aspect, the message we want to drive home is making every contact count. And with regards to sexual health, offer all screening. You know, somebody might not disclose to you that they're sex working, but it's just that trail of thought, they may be sex working. So it doesn't, you know, it doesn't hurt to offer everybody all the screening, all the contraception. There's no point in making them wait. If you know, if you can do it then and there, do it then and there. It might be the only time they come and interact for healthcare. Next slide, please. So with regards to safeguarding, I mean, this could be a whole day on itself, couldn't it? But just as Zoe mentioned, the difference between consensual work and sexual exploitation, modern slavery, which are crimes. In Swansea, we have the sex workers operational team, the SWAT MARAC, and that is where multi-agency approach, so police, health, third sector agencies all sit together on a monthly forum and discuss high risk, usually street working sex workers. The aim of that is how we can all work collaboratively and help. It's usually women, it's mostly women, help these women to get better outcomes in lots of different aspects, not just health. We've got the safeguarding tools in regards to DV and police reporting. And again, it's just driving home if if something is disclosed safeguarding wise, to do an adult at risk referral, and that it is everybody's responsibility to safeguard our patients. Next slide, please. Signposting. So like I've said earlier, this is a huge part of outreach sexual health work, is signposting and referring onwards. Our patients often come with multiple complex needs, and they are some of the agencies we work with there. And like I said, Lynn is going to come on after me from Swan. But it's just finding out again what's in your area, making those links, building those relationships, and you can refer patients on then. Next slide, please. This is us in Swansea Bay, and if anybody is local to the area or needs to refer anybody in, they can contact us on the QR code there. I think the slides will be available at some point. Next slide, please. So just the conclusion there, they're a complex group of patients with multiple healthcare needs. They can be really difficult to engage with, and because of that, we need to develop how we deliver healthcare. We need to be flexible and prioritise their needs. From a sexual health point of view, always offer screening and contraception at the point of seeing the patient. They may not come back for another appointment, you may not catch up with them, they may see somebody else, lots of different reasons. And to think of outside the box, people are not going to present to you as sex workers, they're not going to disclose that to you straight away. You'll need to liaise with other specialities and signpost onwards. We can't do everything for these patients ourselves, but we can create those links and work with others to try and get the best outcomes. And yeah, just to go the extra mile really, because these patients, they mistrust health professionals in particular. They've had some really bad experiences in the past. So it's just about changing that viewpoint for them that, you know, we are there and we will listen to them and help them going forward. Next slide, please. Oh, and that's me done, I think. Any more slides from me? I think references. Thank you.
Oh, thank you, Joanne. That was great. It was a really good overview of what your service does, and really some really lovely points on how we, outside of sexual health services, can support these patients. So that's lovely. Okay, thank you. So we're flying through the agenda, so that's really positive. And now it's over to Lynn. Hi, Lynn. Over to you.
Okay, thank you very much, Vic. All right, hi, I'm Lynn Sanders. I'm the Chief Executive of Swansea Women's Aid. So I'm talking to you today regarding the Swan project and our association with sexual health services. Next slide, please. Okay, so the SWAN project was established in Swansea in 2018. On average, we support 150 women a year. Now, that will primarily be women selling survival sex and who are exploited by the sex industry, but we do also support women working in brothels and online. And the SWAN project is central to the multi-agency response to women exploited by the sex industry. Next slide, please. So as other presenters have said, the key issues for the women is multiple disadvantage. So poverty, often many of them are care leavers, no family support, so very isolated and with transient lifestyles. They're stigmatised, very much sitting outside of society, mistrust of police as well as other professionals, lack of engagement with services. So it takes a lot of effort in order to ensure that services are best fit for the women, for them to engage well. They suffer from poor physical and mental health. And the majority of the women we support are substance users. Many of them have insecure housing or are street homeless, and they also experience high levels of domestic abuse. Next slide, please. Looking at the SWAN project then, it operates across Swansea and in East Port Talbot. So Thrive Women's Aid deliver it in partnership with us in East Port Talbot. This is the service in Swansea. So we have an evening outreach service 4 nights a week. So we have a van that operates in the area where the women are working. Key focus is on safeguarding. So we will, for example, we'll monitor if they're going into cars, if they're moving away from the area, how long they're away, if they return to the area, if there's any disturbance on the street, if anyone is particularly unwell that evening, or basic safeguarding. We address their basic needs. So we supply food, clothing. The photograph there is me and one of our staff standing in front of our stock for the van. So, and that will be, as I said, food, clothing, drinks, contraception, sanitary provisions, etc., and crisis support. So the van is staffed by a mixture of volunteers and paid staff. So there will be three people on the van at any one time. The service is a window service, so the shift leader will sit by the window and will talk to the women as they approach the van, just checking how they are, making sure that they get the coffee, tea, etc. that they want, but also dealing with any crisis support they may need. So, for example, we do out of hours emergency housing referrals. We have ordered ambulances. We have had to call the police if a woman has been assaulted. We've assisted women to report crimes that they report to us at the time. So any crisis support that woman needs. Part of the service is the fortnightly access to the outreach sexual health service. They come up with us every other fortnight, and it very much the evening outreach service acts as the front door into the daytime service. So the daytime service then, so we have a team of daytime staff who are trained in trauma-informed, strength-based needs-led support, and the referral will come in via the van log from the night before, and they will follow that up the next day, ensuring that the crisis needs are prioritised, but then looking very much, the focus very much is around engaging the women, building up their trust, so that they will come to us at times of crisis or to address the things that they need. They can dip in and out of the support. There's absolutely no expectation that they engage for any length of time. And very often they will engage. We'll see them 1 week, we may not see them for another 2 months, but and then other women who have got very high needs will engage with us regularly to ensure that we can signpost them and support them engage with other agencies so that their needs are met holistically, bearing in mind the woman at the heart. The woman is at the heart of all the support that we offer, and very much informed by what they see as their priorities, as well as safeguarding. And we are about to move office in Swansea. So the intention is from April 2025 that we will expand the service to offer a twice-weekly drop-in session. Sexual Health have indicated that they're keen to be part of that. But the idea is that we will have one afternoon a week where we will invite other organisations there so that women can learn what other services are available and can access support. And then another session that will offer more of a community to, like coffee morning plus crafts, etc. As the women inform us that they want, we will develop that on the Friday to encourage them to attend, just so that we can build up that relationship with them. Next slide, please. Okay. These are some of the key issues that we identified in relation to the women in regards to sexual health. So they have multiple perpetrators. So they have their partner, ex-partners, pimps, drug dealers, organised crime gangs, etc., all demanding money or all expecting them to work in order to provide them with their drugs. So, and need for substances if addicted and for partners, I've just said. There are multiple buyers, so in any one evening or week, they are working with multiple buyers. They have no knowledge of their history, and the buyers will pay more for no use of condoms. There's high levels of physical and sexual violence. Obviously, it can be oral, vaginal, and anal sex. Can be multiple men at once, causing difficulty in protecting themselves. Can be deliberately infected by buyers because they're objectified and actually not seen as being human by some people. They're very much seen as being an object that they can abuse. Reporting of offences is low, as other presenters have said. The buyers know they can get away with it currently. And, they can get away with abuse and sexual violence, hence the high levels experienced by the women. So women are on contraception, but can be desperate for money, so take risks. Not a lot of options regarding contraception from the women's point of view. Implants are better, as they do not remember to take the pill. They can catch Hep C, and there's a lack of public bathrooms, particularly in the area where they work, which causes issues when they're using tampons and sponges. And basically, women's bodies are not designed for having sex multiple times a day. And there are real health concerns around that for the women, physically and emotionally. What they report they need is very much a flexible, non-clinical, accessible sexual health service to encourage engagement. Sexual health nurses in the area visit brothels, hostels, temporary accommodation, and will go to a house if a woman is working from there. And most appointments are not at the main clinic. They're at a more local clinic for the women. Next slide, please. Okay, so looking at the joint work we do with sexual health, I have to say, Jo is one of the nurses who comes on the van with us. They offer an exceptional service in Swansea that is very, very women-centred. So this is an outline. So the nurses will advise our staff if there are any health concerns of a particular STI outbreak to maximise the safety of women. So the daytime staff will pass that on to the evening outreach staff, and we will make the women aware that there's a particular concern around that STI. Ongoing liaison to arrange appointments for women. So our daytime staff will contact the sexual health nurses to make an appointment for women, and that'll be vice versa. So safeguarding, we will do joint visits with the sexual health team. We can share alerts or liaison if there are missing women. So perhaps if a sexual health nurse hasn't seen a woman for a while or is concerned around her safeguarding, she will contact us to see if we have had any contact or seen her at the van. And similarly, we will do the same. The police intelligence officer is part of that as well if they have concerns around women's safety. And we can offer support sessions with our daytime team if the women are at risk. Nurses alert us if a nurse needs to see a woman urgently for treatment, and we can pass messages on. We do pass messages on to the women to say that a particular nurse is needing to see her and asking her to make contact. Next page, please. Okay, and sexual health, as Jo said, do sessions in various settings. So what our staff will do, daytime staff, if we're struggling perhaps to see one of the women, then we will piggyback on the sessions that sexual health are doing. So, for example, they offer a sexual health session at Dyfodol and at the Nelson Trust locally, so our staff will attend that as well. They help us facilitate access to gynecological services, so the nurses will make referrals and chase them up for the results, etc. Terminations, obviously a number of the women will have terminations, so, and the sexual health nurses have met the women at the hospital before the termination to offer support. Basically, it's a wraparound service. So we have liaison after a joint appointment with women to allocate actions. So that's, as Jo has said, can be a swap referral, a housing referral, etc. And that wraparound service will involve whatever service is relevant. So that could be the police, it could be sexual health, it could be housing, it could be a drug agency, for example. It's whatever is needed in order to address the needs of the woman. In 2024, the sexual health support that that women access, so 42 women so far, when I did the presentation, had of the daytime women had accessed sexual health, and the evening outreach was 33 women. Next page. Next. All right. I think what I want to say, I haven't got a slide on it, but I think key for engaging with the women is that non-judgmental approach. And what the feedback that the women give to us very strongly is that what am I trying to say? Is that, sorry, I'm doing this off the top of my head, so please bear with me. What the women say very much is they just want to be accepted as they are, for the lives that they have, with the background that they have and the circumstances that they're in. And that is key. So it's all about being judgmental, being open, and having flexibility around services. That what works with the sexual health service in Swansea. The outreach service is very flexible and will go to the women if need be. And I appreciate not all primary care settings can do that, but it is very much thinking around how services can be changed. So I'll give an example without naming any names, but an agency in Swansea was making appointments with women, but they were totally inflexible. So that, and then if the women didn't engage, and there could be all sorts of reasons for that. It could be her partner would not allow her out to the property. It could be because she didn't feel safe, because there were other people that she didn't want to mix with at the settings. It could be that she was just unwell that day, etc. Then they would make up to 3 appointments, and then she would be struck off, which would take her right back to the start of her treatment. So it's just really difficult. And I think, bearing in mind that some of the women have transient lives and are surrounded, as I've said, by perpetrators, there just needs to be that flexibility. Fortunately, that's been built in. It is better than it was, but there still is a bit of a way to go. I shall give a case study. So, and I've changed the name. Anne approached the Swan Outreach Van in 2024, wanting advice from the sexual health outreach nurse. She desperately needed sexual health screening and contraception. With consent from Anne, Swan daytime staff were able to book an appointment on behalf of Anne to see the nurse the following day. The daytime Swan staff supported her to the appointment, where she was able to have full screening and contraception. Anne asked the sexual health nurse for advice around an ongoing health problem that involved her contraception. Sexual health was able to give her advice, but also referred her to see a gynecologist as soon as possible to hopefully get the issue resolved. After around 3 months, the daytime staff supported Anne to the gynecology appointment. The issue was resolved, and Anne continues to have regular sexual health screening and is up to date with her contraception, which is a really excellent outcome for her, given that she has a very transient lifestyle. Next slide. So our contact details, should anyone need to make contact, it can be a self-referral or an agency referral. and that gives our number and our email for the Swan project. Thank you very much. I think that's it.
Oh, fab, thank you. Everyone's welcome to turn their cameras on now, and if anybody has a question for any of our speakers, please feel free to pop your hand up and I'll come to you. Or yeah, is there any questions first off? Okay, no problem. I'll go first then. What I think would be really good for our audience is if we can go through all our speakers, and if you can just give your top tips for engaging with primary care on how to engage with individuals that might be sex working in their area and how they might be able to make their services. I think it's been covered, but if there's anything else that you would like to add on how we can support this population group. So should we start with you, Zoe?
Yeah, I think it's a case of not assuming that people aren't having to do sex work. So if you do it as a kind of almost like a blanket approach, it's a bit like I beat the drum about normalizing testing as well. But just consider it for whoever is sat in front of you, regardless of gender or anything else. Just think about, actually, this is a whole person and they come with a lot of baggage. All of us do.
Okay, lovely. Thank you. Joanne?
So we pinched my answer. No, I think, yeah, it's the same thing, isn't it? That holistic care, looking at the person as a whole, and it's building that relationship. I think if you're in a position, I appreciate some people maybe in very busy environments, but if you're in a position to see that person again, you know, if it's somebody that you've identified that, you know, may potentially be sex working, or if they've disclosed it to you, or DV, any of the inclusion health stuff, really, if you're in an opportunity to see that person again and build that relationship, they will become so much more comfortable with you, and, you know, you can really make a difference and really help them.
Lovely. Lynn?
Okay, well, I don't think I've really got anything to add, really. It is very much about just having that open regard of the women, and yes, anybody can sex work. I mean, years ago, when I was a teenager, so it was a while ago, you know, I lived at a bedsit, and I shared the bedsit. We both worked in banks at the time, and she sex worked so as well, because if she was short of money, she would sex work, and no one ever would have thought that was what she would do at weekends in order to make ends meet. And I think from a very early age, I recognised that it really can be anyone, and you never know someone's circumstances. You only know what they tell you, but there's an awful lot that people choose not to tell you regarding their personal circumstance. But there can be indicators of the substance misusers, that they're struggling with money, they're living quite transient lifestyles, they're going to be more open to exploitation and be more vulnerable, which is an indicator that there is a possibility that sex work can be there. So sometimes it is just about joining the dots and perhaps thinking slightly outside of the norm.
Okay, lovely. We've got a couple of comments that have come through. So Sandra says it's good to see the services have expanded, Lynn, so that's nice.
Thank you, Sandra.
And Lucy asked, what services are available for men, trans men, LGBTQ plus sex workers? Where should we be signposting these people across Wales?
I'll take that one. If you link in with Safety First Wales, they will be able to link you into other services, because it's a wide coalition, and that might even have to bring in people from England, services from England that can support. But also the sexual health services, they will support everybody, including LGBTQ plus, etc.
Cool. Zoe, do you think we could put the link to a Safety
Just about to.
Oh, great minds. Fab, thank you. Okay, lovely. Is there anybody else that has any questions. We are really flying for time, so I'm going to be able to give everybody back a bit of time for their day. But is there any other questions before I bring in Fatima? Well, if you have any, well, Fatima's just going to talk to everybody just quickly about the inclusion health networks that our team are running. And if you have any questions, pop them in the chat and I can ask them after. Fatima?
Thank you, Vicky. Good afternoon, everyone. Fatima Sayedin, Principal Public Health Practitioner with the Primary Care Division of Public Health Wales. Just wanted to let everybody know that we have got an Inclusion Health Nurses Network that is running, would I say, probably in its last 1 year. Joe, would I say, would that be correct? It is a network of health professionals, although we call it nurses network because it was initiated initially by nurses who did work on health inclusion support services, and it was chaired by Janet Kiefling. But this network is open to all other professionals and people who are working or providing services to people within the health inclusion communities. So I just wanted to let everybody know, if you would like to join the network, it's an open platform, very friendly group of people, and the key purpose is to get together for shared learning and networking. Usually it's quarterly for an hour. People meet and we have got presenters and speakers and people present their services, shared learning. So really nice group of friendly people. If people would like to join, please let us know and we will include you in our distribution list. And our next meeting is on the 11th of March on Tuesday at 2:30.
Yeah,
so I don't know, sorry, I don't know, Laura, if you wanted to add anything else. Not Laura, sorry, Joe.
No, I think you covered it, Fatima. Yeah, I can't think of anything else to add there.
Thank you.
I'll pop my email in the address, so if anybody wants to, they can let me know and I can put you in touch with the network then. That's great. I've just got one more question about how primary care should be linking in with their local services. So I know you guys are from Swansea Bay, and I think there's some people on the call from broader, but like, what is your advice in getting involved with services like yours, Lynn and Joe, for primary care? That how would they find you? How would they engage with you if they hadn't have attended this?
I think for myself, for sexual health, I think, and you know, other places can look at what's offered from the sexual health department. I think most sexual health departments run a little outreach kind of program. I think us in Swansea Bay are quite proactive. We've got quite a large kind of outreach cohort. But contact your local sexual health department, really. Ask them, you know, is there outreach? What's the scope for outreach? Is there somebody who is like a link nurse who specialises in outreach, and go from there, really. If you are Swansea or Port Talbot, you can contact me or the main sexual health department in Swansea Bay.
Lovely.
And I think for actual specialist services, there is a service in Cardiff and in Newport as well. So Street Life in Cardiff and Horizon in Newport as well. There are sexual violence services across Wales. There's Rasach up in North Wales, there's New Pathways down in South Wales. They will also support women who are, or people who are sex, they're not gender specific. So people who are sex working and experience sexual violence as that. But there's not a huge amount of specialist services, but most violence against women, domestic and sexual violence services will, if people are experiencing sexual violence, will have a service that will support that, and that can incorporate sex workers as well. And you can ring, there's the Live Fear Free helpline in Wales, 0808 80 10 800, and that if you ring that as a professional, they will give you the contact details of your local service.
Oh, amazing. Would you be able to put that number in the chat? So, because I've forgotten it already.
Yeah.
And then it's there for everybody. We've had a comment from Julie who says in CTM, we also have a service called Choice, which is fast-tracked access to specialist sexual health team. So that's really, thank you for sharing that. And then Chiquita asked, I think it would be helpful if I could link up with, someone would like to, Chiquita would like to link up with a primary care lead nurse group to discuss. So I will get in contact with you directly, Chiquita, so that's great. Okay, well, I think unless anybody has any more questions, I can give you back a fair bit of time to your day, because it's been a really informative and lovely hour to be a part of. But yeah, if there's no more questions, then I think, you know, everyone gets a bit of time back. And thank you ever so much to Zoe, Joanne, Lynn for your time. And Rebecca has just popped a feedback form into the chat. So if anybody has time and is able to provide us some feedback, that would be really great. This is the last one, Inclusion Health webinar we have planned. But if you have any ideas of what you think might be helpful, or webinars you'd like to see in the future, please feel free to contact me or Rebecca, and we'll be able to have a think about next year and what we might be able to do to keep this momentum going and keep Inclusion Health on the agenda. So yeah, so I think that's it. Thank you everybody for joining, and thank you for our speakers, and we hope to hear from some of you about joining the Inclusion Health Nurses Network.
Thank you.
Thank you everybody. Bye.
Thank you.